Okay, everyone, I think we've got about 60 people here and there's 150 people signed up, but I think we'll get going as you know that everyone's quite busy. So good afternoon and welcome to today's webinar, From Knowledge Production to Clinical Practice, Risk and Pregnancy. My name's Rebecca Blaylock and I'm the Research and Engagement Lead at the Centre for Reproductive Research and Communication at BPAS, the British Pregnancy Advisory Service. And our research centre was established in 2019 and exists to develop and deliver a research agenda that furthers access to evidence-based reproductive healthcare and choices. As a research team, we've got experience of conducting research on abortion, contraception, pregnancy and public health. We have expertise in clinical practice, epidemiology, medical ethics and law, and the social sciences. Today's webinar has been convened to share the findings from the WRISK Project, which was a collaboration between BPAS and Cardiff University, funded by the Wellcome Trust. WRISK was the brainchild of Clare Murphy and the late Dr. Heather Trickey, and they came together over a shared concern that women receive many public health messages relating to pregnancy, which are of course intended to improve outcomes for babies and their mothers. However, negotiating the do's and the don'ts of the risk landscape and the maternity care system can feel confusing and disempowering and can sometimes lead to negative outcomes for women themselves. Our study engaged with over 7,000 women to hear about their experiences of public health or risk messages in pregnancy. Today, we'll showcase their stories and shed light on how their experiences relate to the way that we do research and science, how we report study findings in the media, and how we communicate risk in the clinical environment. And I'm really excited that we'll also be hearing from this year's winners of the Dr. Heather Trickey Essay Prize. So without further ado, I'd like to introduce our speakers. Starting off today is Clare Murphy, who's the Chief Executive of BPAS. She's also a board member of the European Consortium on Emergency Contraception. Clare led the External Affairs Department at BPAS for many years after she was a health journalist at the BBC, and Clare was the WRISK Project Principal Investigator. We'll also hear from Professor Julia Sanders, who's a registered midwife and nurse and a researcher. She holds a joint post between Cardiff University and Cardiff and Vale University Health Board, as well as several external national leadership roles. And Julia was a researcher on the WRISK Project with me and Clare. Next, we'll hear from Professor Marion Knight, MBE, who's a Professor of Maternal and Child Population Health at the National Perinatal Epidemiology Unit at Oxford University. Her work focuses on using national observational studies to address clinical questions concerning rare and severe complications of pregnancy and early life. And I'm sure that many of you will also know her from the Embrace UK National Confidential Inquiries into Maternal Morbidity and Mortality. We'll also be hearing from the winners of the Heather Trickey Essay Prize, as I mentioned earlier, Sarah Fishburn and Angelina Connor, who are from the Pelvic Partnership, and I'll formally introduce them to you later. In the meantime, please do use the chat to introduce yourself. I'd really like to hear where you're from and what you're up to. And you can post questions in the Q&A box as they come to you. And once we've heard from all of our speakers, I'll field questions for them. So I'd like to hand over to Clare Murphy, who's going to talk you through a little bit about how the WRISK Project came into being and what we intended to do with it.
Well, thank you so much for that introduction, Rebecca, and thank you so much to all of you for joining us today to talk about a project that is incredibly dear to my heart. As Rebecca said, it's a project that I started with a very dear friend, the late Dr. Heather Trickey. Really, that we came together over this shared concern about how women were experiencing risk messaging in pregnancy, and really rooted in the context of a recognition that it felt like we were living in an increasingly, in what I still think of as today and now, quite what I would describe as a sort of fetal-centric environment, where women's own needs and requirements aren't always necessarily appropriately recognised. And really recognising as well that this has consequences not just for women themselves, but also for their pregnancies. and the idea of the WRISK Project really was to start opening up a conversation about these issues and to really think about how we could start putting women's own needs front and centre and really articulating this idea that women's needs and those of their pregnancies are actually intertwined and that we can't serve one without the other. One of the first pieces of work we actually did with this project, so Julia will go on to talk about the findings of our surveys and the interviews that we did. But one of the first pieces of work we did was a piece that was really sort of trying to kind of set the landscape and which looked at the kind of research studies around pregnancy that were appearing in the public domain. So we undertook an analysis looking at media articles over a period of a year. And really looking at the kind of questions that researchers were asking when they were investigating pregnancy. And one of the key findings that came out of it is that when studies are often conducted and the kind of studies that get funded, or at least those that go on to take up our media headlines, that the focus is often on outcomes for the pregnancy, on short-term or long-term outcomes for the offspring themselves. And that the mother, and it's normally the mother who is the focus of attention as opposed to the parents, the mother herself was often positioned as the vector for harm, if you like. So, what she did or didn't do during pregnancy, how she behaved, what she took or didn't take. And very rarely, actually, were we coming across studies, at least those that were being reported, that were also looking at the consequences for women of pregnancy, that the focus really seemed to be around the woman herself, what she did, and what the outcomes were for her children. And I think, one of the reasons we wanted to start off by doing this piece of work was really to sort of set the context for the way in which women experienced pregnancy, and the clinicians around them and those who support them. What is the climate in which women have lived experience of pregnancy? I also wanted to use this introduction to explain a little bit more about why this area mattered to BPAS in particular, and why this landscape caused us concern, because I think people may well, and rightly so, think of BPAS as a charity supporting women who are ending pregnancies rather than those who are continuing them. And I think for me it was really about recognizing that this landscape, if you like, impacts upon women in a number of different ways, and certainly from a sort of practical perspective. At BPAS, so we're an organisation who sees around 100,000 women a year considering abortion, sometimes because it's just an unplanned and unwanted pregnancy, sometimes because it's not necessarily an unwanted pregnancy, the pregnancy that they can't continue in the circumstances that they find themselves in. And I suppose being in that position of seeing so many women and hearing so many experiences, it's also put us at the sharp end, if you like, of where risk messaging in pregnancy goes wrong. So over the years, yes, absolutely, we've seen women who have considered ending a pregnancy based on very acute anxiety over alcohol consumption during pregnancy, even at very low levels, because they have taken on board messaging which communicates to women that even small quantities of alcohol in pregnancy can cause long-term harm, even though the evidence base, as we know, on this is conflicted, and that actually what we see around sort of pregnancy and public health messaging is that we take a different approach to evidence and risk communication than we do in other areas of public health promotion. And that when it comes to pregnancy, the positioning is very much, it's better to be safe than sorry, rather than the kind of informed consent approach that we see in other areas. And and we should be very clear, and this is one of the things that's come out of our of the questions we ask women, is that women themselves are also supportive of this better safe than better safe than sorry approach. But it's really, for us, it was about trying to surface what some of the consequences of that are. And, you know, as I say, certainly from a BPAS perspective, we'd seen that with alcohol consumption, but also with issues like you know, women suffering very severe morning sickness or hyperemesis, who'd simply been unable to access medication to alleviate some of their symptoms. You know, women being told that this is simply a part of pregnancy, and you know, and something that you just need to put up with. And you know, these were women who really had just got to a point where, particularly if they you know already had children, where they simply couldn't go on. And that, you know, were left with no choice but to end that pregnancy because they couldn't access the medication, even though we know that there is safe and effective medication available. By the time they'd got to us, they'd really sort of crossed that Rubicon. So I think there are some very practical implications, but also, you know, from my perspective now as well, you know, as the Chief Executive of BPAS, it's also about some of the philosophical framing, if you like, around this. You know, I think sort of politically and practically, we've divided up women into, you know, different camps, if you like, according to their pregnancy intent. You know, and we see women who are ending pregnancies as a very different group of women to those who are continuing them. Whereas, you know, in reality, they're often women at different points in their own particular reproductive journeys, and you know, it's very depressing, for instance, to see the local women's the latest women's health strategy, although it covers abortion, although it covers pregnancy rather, it leaves abortion out of it because these are just a different category of women. And I suppose from my perspective, it's really important that we do join the dots on some of these issues, because a focus on the fetus and this sort of fetal centric approach, if you like, has implications and consequences for women's choices, actually regardless of their pregnancy intentions, and it constrains what women can and can't do. And I think over the last couple of years, actually, we've seen some really pertinent examples of where this approach starts to compromise women's health and well-being. You know, I think a really good example, for instance, is some of the discussion and implications of the decision making early on around the rollout of the COVID vaccine, and where pregnant women sat, you know, within that, initially excluded on the basis that we couldn't possibly tell whether it was safe in pregnancy, even though there were no possible mechanisms of harm. And then actually, by the time it became clear that pregnant women, you know, were, if anything, more vulnerable once infected, it was then very difficult to persuade women to take this up because of that messaging that had gone out there. You know, I have to say personally, I'm really horrified at the place where we are now with sodium valproate, you know, a really effective medication for women suffering from epilepsy. You know, and this is now not just that women can't have it if they're pregnant. This is now, you know, clear restrictions on women who don't even have any intention of pregnancy. So now we're protecting fetuses that don't exist, hypothetical fetuses, from the actions of women, and I think that's a real problem. The WRISK Project really was set up to start opening up a kind of conversation about some of these areas and how we can start reframing our questioning. And I'm not going to suggest for a moment that that we've solved that. You know, I think we're at the very start of a journey. And actually, what I kind of think is that, you know, some of the examples I just gave you, actually, I think have perhaps brought to greater attention where some of these tensions exist. And, you know, I think one of the other aspects we were, you know, really keen to bring forward with the project was really trying to better understand how a number of broader social concerns sometimes play out on women's bodies and, you know, and mothers' bodies. You know, I think for all of us as a research team, some of the most difficult findings actually were about the experience of women with higher BMIs during pregnancy, and how they personally were made to feel that they were harming their baby, that, you know, their baby would have lots of long-term health problems because of their size and weight. And, you know, I think this very individualized understanding of risk sometimes, and how it plays out for the individual woman, I think gave us all real cause for concern. These are, you know, obesity is a broad social issue which probably needs broad social responses, rather than this very individualized approach, which I think, you know, the women who were in that situation experienced very, very negatively. And I do think, you know, to sort of come full circle, that this for us was, you know, the best place to start is how can we surface women's experiences? You know, how can we put women front and center? And, you know, Rebecca said that we're joined today by Angeline O'Connor and Sarah Fishburn from the Pelvic Partnership, who are the winners of this year's Heather Tricky Prize, which this is the second year we've run it. And, you know, the idea of this prize really is to do just that, to surface underexplored women's experiences. And they have put forward, you know, put in a really excellent couple of essays on women's experience of pelvic girdle pain. And how they are expected to tolerate it. And I have to say, you know, to my shame, despite all this interest in all these areas, and, you know, the way we've been thinking about it for the last few years, this is an area that simply never occurred to me, but one that actually, you know, is the absolute manifestation of exactly these sort of issues, that this is an area that women are just expected to put up with. And I was saying to both Angeline and Sarah when I was talking to them about their essay that I'd done a bit of Googling around, you know, what NHS Trust said to women about this. And literally the first paragraph on one site was, yes, you may be in pain, but don't worry, there's no risk to your baby. As if, because that's the only thing that matters. And I think that's what we need to change and shape, that, you know, that women's experience does matter. It does need to be front and center. And it's opening up that conversation, and, you know, and really taking that forward, which, you know, is exactly the point of all coming together today, that I think is where we're going to get the answers. So I'll stop there. I'm going to hand over to Julia, but yes, I know Heather would be absolutely delighted with where we are now, and really having this conversation. So, as I say, thank you so much for joining us today.
Thank you, Claire. And just as an aside, I'm just looking at what everyone's putting in the chat and all their projects and PhD projects that they're up to. It's absolutely fascinating. There's some, I think we just need to get ourselves all in a room together at some point. Thank you, Claire. I'm now going to ask Julia to unmute herself, and she will be presenting the findings from the different work packages of the WRISK project. As some of you may know, it was a multi-year project, over 7,000 participants and lots of different organisations involved. So Julia has a mammoth task here to try and get all of those findings from 4 different research papers into a short presentation, but I know that she'll do a really good job. So Julia, over to you.
Thank you, Rebecca. I'll just start sharing now. Cool. So thank you for those warm introductions, both from Rebecca and Claire, and that scene setting. And yes, and I've got the wonderful task this afternoon of sharing with you very briefly some of the main findings from the WRISK study. I will be mentioning the publications, and of course there'll be far more detail in those papers than I'm able to share with you this afternoon. And right at the very beginning, I must give credit to our wonderful friend and colleague, the late Heather Tricky, and I will put up a public warning to her friends and family that there is a rather lovely photo of her at the end of this presentation. So where did it all start? Well, as always, the very best projects are done in collaboration with people. So you'll see the all these institutions and groups were very much involved in the direction and the tone of this project, which really wanted to hear the voices of women and put women at the centre of absolutely everything that we explored. And as Claire's explained, the background to this was this overriding enthusiasm as viewing pregnancy as a teachable moment and wanting to share very important public health messages to improve the outcomes of population and also for women and their babies and individuals. But there was a feeling from a very large group of people that got together that there were also potential negative consequences to that. And there was the erosion of normal, healthy pregnancies, and that sort of joy of being pregnant was perhaps being slightly eroded by the women increasingly being labelled with risk factors, being bombarded with messages about what they shouldn't do when they're pregnant, but also around how do we set the scene, what's their experience of women, and getting that balance between a public health message and how that's taken on board individually, and how do women receive these messages. And also then more recently, the introduction of sort of technological surveillance, carbon monoxide testing, and even the prospect of, I'll talk about alcohol monitoring in meconium samples of babies. So what was the work that was done? Well, it all looks that you can see that time has passed, but there were three main components to this work. There was a media content analysis, which I'll talk about, which described basically how are these public health messages presented in the press and in the media, and then an online survey to collect women's views, and then very much in-depth interviews, which were conducted by Rebecca and Heather. So just thinking first of all about the risk messaging in the media analysis. This was conducted primarily by Olivia Marshall, who did a fantastic job and came with completely new methods that to many of us, to looking at what is it that's out there in the press. And these are the sorts of headlines that women see, that women are exposed to on a fairly regular basis. And what we were interested to know was, what's that pathway and what's the link from research funding through to projects that are conducted, but then through to the findings, the headlines, and the messages that are received into the public domain. And Olivia explored that pathway. So what Olivia did was examined headlines that were in the press over 4 months, so 4 set-month periods, and she looked at the number of headlines and the number of stories that were published. And just totting up those figures, you can see that on average, every day there will be something in the press reporting about pregnancy and risk. So this is not a minor activity anymore. This is mainstream. What's happening to pregnant women? What messages are out there? And just looking at those number of stories, there were 56 unique stories. And the main categories were around food and drink, what women perhaps should or shouldn't drink, completely from the bizarre to eating more broccoli, the effects of eating more broccoli when you're pregnant, not surprisingly then to include effects of alcohol, medicines, but genetic factors, stress, exercise, a multitude of every aspect of women's lives were really being put under the microscope to consider the impact primarily on their babies. So what did Olivia find from these messaging? Well, certainly a very rich mixture of messages going out on a very frequent basis, and perhaps not surprisingly to us, but it's nice to have it described, is that when it came to risk factors, it was very woman-centric. So advice on what women should do, what they shouldn't do, what are the impact of maternal activities on their pregnancies. But when it came to outcomes, it was far more focused on babies. So what's the impact of maternal and mother's behaviour during pregnancy on their baby, very much more than for themselves? And unfortunately, there is this sort of environment and atmosphere now in studies that can portray women's bodies as risky, as something, and their behaviours that need to reduce risk in pregnancy for the benefit of their baby. So the specific examples that were looked at, there were a few, and these were very much individual stories around caesarean section and the longer term impact on babies, positive thinking during pregnancy, nut consumption, and one particular study which received a large amount of headlines around the prevalence of fetal alcohol spectrum disorder. So that's the impact on babies and children from alcohol exposure during pregnancy. But what was found, which was perhaps not quite what we expected, was actually that the study findings were actually pretty largely reported accurately in the press. So they weren't twisted, they weren't exaggerated, they were actually reported as intended and as found. But having said that, there were caveats that were omitted, and really importantly, none of the headlines, none of the stories included figures on the relative risk as well as the absolute risk. So the headline may read, women double their chance of having whatever their effect is on their baby, but without perhaps describing that the baseline rate is 1 in 1,000 and that doubles to 2 in 1,000. So it's really important that it's recognised that that's an area for improvement in all reporting. There were often quotes from authors, and sometimes, as you would expect in the press, sometimes they went off on a slight tangent and linked in other stories that weren't really linked. So, but generally it was found that the media reports were actually faithful to press releases that had been released by study teams, and there was effort to include expert opinion, but with some rounding up. So as I say, the methods were really interesting, and if you want to read more, then that reference will be there. Sorry, my slides are now refusing to go on. Oh, sorry, I may have to stop sharing and come back in again. Let's see if I can. Oh, there we go. Did you do that, Rebecca, or was that me?
I think it was you, but it's working. Okay. That's the important thing.
Just wondering. So that was the media study, and then also particularly driven by Rebecca and Heather was the WRISK Voices studies, in which we went out and found and explored the views of women towards the public health messaging, particularly in pregnancy. So there was a two-stage approach to this piece of work. There was a survey which was conducted completely online, which received over 7,000 responses in under 3 months. And I think if we needed a marker or an indicator of the interest that women have in this subject, that must be it. There was absolutely no difficulty at all in women engaging and wanting to tell us their stories. And then we were particularly interested to hear the views of women with particular experiences in their pregnancy. And so following this, many women offered to be interviewed and to be further engaged with the research. But Rebecca and Heather carried out 34 really in-depth interviews using a purpose sampling frame to make sure that the views of women were heard with particular experiences of their pregnancy. We wanted, and these represented the interests of the lay groups that were involved in the study. So we wanted particularly to hear the views of women with hyperemesis, that's with severe morning sickness or severe sickness during their pregnancy, younger mothers, particularly mothers on mental health medication or with mental health difficulties and their experiences of gaining support, women with a raised BMI, women that had experienced a risk-related termination of pregnancy. As I say, this is the real extreme end of risk messaging, when women feel so afraid of the potential for harm, even if that's only minor, that they feel they can't continue with their pregnancy. And also some general points. But this list just gives you some idea of the entire spectrum of women's lives. Women never come in little silos. They come with complicated lives and exciting lives that we should want to know about. And there were many, many aspects covered within the interviews. And we particularly wanted to explore this idea about this principle of it's better safe than sorry, which informs much public health messaging. The idea that women should be told if there's any risk at all, just avoid that activity, and then you'll avoid the risk, and there will be no concern about it. And what we actually found was, for many women, that was an acceptable message. As this woman explained, I think the better safe than sorry approach is fine, but providing it's explained and people are given the information on which it's based. But equally, a similar number of women felt that in doing that, we're really underestimating the complexity of women's lives, and that it's actually just really frustrating to be told to try to modify behaviour, which can be very challenging, and not looking and giving messages really in the context of women's lives. And it's really important that we're always very conscious in giving these messages that they can have really negative impacts on women, not just as individuals, but perhaps the way that even if they feel that other people are viewing their history and their actions. So this survey respondent said, she was someone who'd had experienced repeat miscarriages, and she said her threshold for what is an unacceptable risk, whether it's drinking, exercise, smoking, was very low, and understandably. But then she went on to say miscarriage is almost always exclusively discussed as a risk pertaining to certain behaviours, and doctors and midwives try to discourage. And to a certain extent, I think this creates an impression in the minds of women who miscarry and the general population at large that miscarriage is caused by something that a woman did or didn't do. Now, I'm sure that anyone who cares for women who have experienced a miscarriage or experience a miscarriage try very hard not to give that impression, and to want to reassure and give women information that that's not the case. But with so many other messages and conflicting messages, we need to be very conscious of the experience that women are having. So we asked women, what were the issues that are explained really well to you? You're bombarded with information as soon as you even step foot for that booking interview. You're bombarded with information. What are the issues that are explained well to you? And maybe not surprising, the issues that women said explained well were those that have very definite public health messages behind them, very clear messaging around what to eat or not to eat, drink, use of alcohol in pregnancy, smoking, and vaccinations. just bearing in mind that this was pre-COVID. But women felt particularly that these were the aspects that were well explained to them. And if you look at any website, there will be very clear information about this is what's recommended or not recommended. And we asked them to tick the top 5. And actually, you can see very quickly it drops down to only about 1 in 5 women felt that place of birth was discussed with them in a way that they felt was well explained. And that's certainly something that we need to be exploring further. Equally, we asked women what could have been better explained. And then we enter this sort of area which is far more complex when there perhaps aren't clear messages and it needs to be more individualized. Exercise and physical activity during pregnancy, women felt they needed more explanation on. But absolutely topping the bill was how to manage their mental health, how to manage stress and anxiety during pregnancy. But also medicines were an area where women felt they needed to be better explained and more information. Infections, and I'm sure that again, with the pandemic probably would be increased, and also preparing to feed their babies. Where things are, so these are topics where perhaps the messaging is not as clear, and it does need to be individualized and take real account of the woman's situation. And this was fairly a sort of typical comment from a woman who said the effect of stress, anxiety and depression, particularly on the baby, was talked about, but not how to manage it, not how to seek help. And ultimately, if we tell women not to worry and tell them it's important they don't worry, but don't support them not to worry, then it's not surprising that could actually exacerbate their anxiety and concerns. So what came through was a real mismatch on occasions of the information that women were provided with and were being given compared to those that were actually required. So as this woman said, although I didn't smoke or drink, I received much better information on this than anything else. I didn't receive any information on maintaining good mental health during pregnancy. So we're very much in the situation at the moment where we bombard women with more or less the same information. And this is a little extract just from another paper that explored public health messaging and midwives' experience. And the situation now, as this midwife described, was they have a computer program that they use for each antenatal checkup. And you have to tick all the boxes to say that at each visit you've talked about whatever public health issue it is. And every time a new public health issue comes up, there's a new tick box to tick. And yet there's little thought perhaps about individualizing that at the beginning of pregnancy so that it can be as individual as possible. Just picking up on potential other implications and potential negative consequences. This is just around the issue of midwives now being required to monitor carbon monoxide levels in all women, even when they report that they're not smokers. And what impact does that have on relationship? And as a woman said, I thought it was bizarre asking someone about smoking when you know they don't. The woman says, I don't smoke. But then we say, well, I'm sorry, we need you to blow into this device so I can actually see how much carbon monoxide is in your blood anyway. And again, that's about ticking a box to report to say, I've tested every woman for carbon monoxide. But we need to explore the potential, at least, for negative consequences of these interventions. So just moving on then to the issue and their experience of women who have raised BMIs and live with obesity, I think it's fair to say that all the comments that came through from women were negative, and really sad comments. So, for example, from the start, I felt like a lesser person. I was made to feel awful because I have a high BMI. No one looked at me as an individual, but just instead a number on a scale. What a sad reflection of women's experiences of antenatal care. And one woman said, I have a high BMI and was made to feel like I didn't deserve to be pregnant. And my weight dominated every conversation. And women talked a lot about the negative impact of the way in which that they were spoken to and the messages that were not individualized. So, for example, this woman said the harm being fat was doing to my baby, long and short term, was mentioned repeatedly. I felt it was an overkill, to be honest. I couldn't do much about my weight once pregnant. It would have been more appropriate to give advice on limiting weight gain rather than talking about how much my baby was being harmed. This is clearly an area where we need to consider how we can better care for women with raised BMIs. And I know that this is a subject that Marion, I'm sure, will pick up on again. But we particularly wanted to hear about women's experiences of medication in pregnancy. And we know that for many years, women have, the message has been avoid medications to as much as possible. But what we found was a complete chain of medication, which it's almost a gauntlet of running the gauntlet to get correct medications. And whilst some medications were readily available and readily used, for example, iron for anemia or antibiotics for infections, particularly when it came to issues such as antiemetics for pregnancy sickness, antidepressants, or other mental health medications, and analgesics for when women were in pain, there was a complete chain that they had to get through, and every single one of these points in the chain could be broken for some women. So starting with a lack of knowledge, women were saying that their GP reported that although you're very sick, there's nothing I can give you, despite very clear guidance from the Royal College of Obstetricians and Gynecologists. There's nothing I can do, go away and put up with it. But then also many women experience conflicting advice. So one woman said, I was advised by my GP to continue my antidepressant medication, and my midwife continually questioned this decision. I mean, we've got to somehow get round this undermining of different professions. And women were always faced with trying to balance risks between the potential benefits of medication and the feeling that they would rather not take things. But that's not helped when the professionals themselves say, I'll prescribe it, but try not to take them because we can't say that any medication is safe in pregnancy. We need to be more aware about what impact that's having. Women experience much anxiety and stress, compounded by the system itself that's meant to be there to reassure them. Maybe surprisingly for me, we found quite an impact that pharmacists were having. So even once the woman had got an appointment, discussed her needs with someone and had been prescribed the appropriate medication, on occasions pharmacists refused to dispense or undermine that decision making, with some women being described as irresponsible for wanting medication, and other women describing how pharmacists just refused to dispense what had been described. So somehow we need to explore this chain to ensure that women can have the confidence that they should be having to receive and be able to take the medications that they need during pregnancy. But of course, what we really want to know is how can we make things better. It's very easy to put across a whole load of miserable stories, but what we want to know is as health professionals, how can we, what should we be doing? What are the positive things that will help? And clearly, what women wanted was midwives, and this would apply to any health professional, who actually answered questions by explaining the evidence, being knowledgeable, and being able to explain their decision making rather than just prescribing or refusing to prescribe. And one woman who was in chronic pain, we don't know for what, said, my midwife did so much research and spoke to consultants about the safe level, how it might affect me, my baby, and also in breastfeeding. Women deserve and need knowledgeable health professionals, but it's also about relationship building and having continuity in relationships and in information, so that women can get the care that they need and the information they need. So what do we hope will come out of all this? We need to develop materials, we need to develop trust, choice, and information that women can actually act on. And these were the key themes that when talking about what went well during communication in their pregnancy. So overall, what did we find from this major study? That current public health messages focus on changing maternal behaviour in individual women. And so far, we seem to avoid the more complex issues such as deprivation, the impact of deprivation on women, and I'm sure we'll be seeing this more now with with poor diets, women in unhappy relationships. What's the impact of that, and how can we support women? Importantly, women are often currently not provided with absolute risks. They're only provided with relative risks, which means they're told there's a double the chance of something happening, but without being given the real information to make an informed choice. We need good communication for trust and maternal well-being. Well, I don't think there's anything new in that one, but also let's all go out there and really remember that we need kindness and compassion during every conversation with women, because women experience complex lives and lifestyles, and we need to make sure that messages are appropriately targeted and are sensitive to the lives that women are living. And here's my lovely photo of Heather. So thank you to the wonderful Heather for driving forward this work. And I hope we do you credit.
Thanks so much, Julia. Can't believe you managed to get all of that content in. It's absolutely fabulous. But of course, there's lots more in the 4 papers that have come out of the project. And the 3 that have already been published have been posted on the Eventbrite page, so you can access them there. They are open access, so everyone should be able to get them. But if you can't, please drop us an email and we'll get them to you. And we do have another paper forthcoming in BMJ Open, which we were hoping would be out by today, but it should be out in the next couple of weeks. But now I'd like to hand over to Professor Marion Knight, whose work at Embrace really sees, I guess, the sharp end of these public health messages in its absolute extreme, resulting in the loss of life of women and babies in England and Wales and Britain. And so I'd like to hand over to Marion now and see you all shortly. Thank you.
Thank you very much, and thank you for the fantastic WRISK project, which, as you will see, echoes so clearly with what I see and hear in the course of my work with Embrace. And this is just an example, as Rebecca just pointed out, of the really sharp end of the stick. So a woman with learning difficulties had increased seizure frequency in the first trimester. She had stopped her anti-epileptic because of concerns that it might harm her baby. She was referred to the emergency department by her midwife because of that increase in fits, but the emergency department didn't make any change in management. She was referred to her GP, who did assess that she was at high risk from her seizures and their consequences, but didn't make a change, but referred her on for further assessment. And sadly, she died from sudden unexpected death in epilepsy 2 days later, before she saw either a neurologist or an obstetrician. And when we think about what women are dying from, if you look at all of the bars towards the left-hand side of this screen, you will see that all of those entail women taking medication for either medical or mental health comorbidities during pregnancy. So this will only become an increasing concern that we need to think about when dealing with our pregnant population. And we don't just need to think about women who are dying from indirect causes, so from medical or mental health related causes, because if you look at this fourth pair of bars along, you can see that of all the women who die, including those who are dying from conditions like preeclampsia and postpartum hemorrhage, nearly 2/3 of them have pre-existing medical conditions and therefore will have medication needs. And as I will come back to, and as Julia's just been talking about, recognising the impact of severe and multiple disadvantage amongst these women is really important. When we think about pregnancy, we often don't move into the postnatal period, but as I'm sure all of you on this call will be very well aware of, we see many of the same problems when we're thinking about breastfeeding and when we're talking about risks and risk perceptions. And again, looking at the causes of women's death in that period between 6 weeks and a year after the end of pregnancy, when many women will be breastfeeding, the same themes occur, so medication will be needed. And just to go back to epilepsy, and again to see the impact of changes, and particularly concerning changes in terms of medication use during pregnancy. And we have seen a recent rise in the number of women who are dying from sudden unexpected death in epilepsy. And time-wise, that relates directly to the Valproate pregnancy prevention programme. And as Claire pointed out at the beginning, we now have even more drastic changes proposed for women of reproductive age, not even women who are pregnant. And when we look at the women who are dying from epilepsy, a quarter were not taking any medication. Fewer than a quarter had documented pre-pregnancy counselling. Less than a third had specialist review during pregnancy, and the majority had uncontrolled epilepsy pre-pregnancy, i.e. Their medications had not been optimised. And our assessors felt that we could have prevented nearly 2/3 of their deaths. And it's this recurring message, which is where, you know, for me, the WRISK Project has so many parallels, that we must always be thinking about benefits and not just risks when making decisions about medication and pregnancy. And we highlighted as part of this that really there is no point in ineffective treatment in epilepsy. We need to make sure that what we are treating, how women are being treated, is giving them effective seizure control. We still see deprescribing, which underpins women's deaths. And this, again, tunes very strongly with some of the themes Julia mentioned. A woman died by suicide in her 3rd trimester. She had a previous history of anxiety and depression. She had good effect with the medication that she was taking prior to the pregnancy. She stopped it on discovering the pregnancy. It's not clear whether that was the woman herself or her GP. And as she became worse, she was asking to restart her medication. And it's documented in her records very clearly that the GP was placing all of the responsibility on the woman and emphasizing the risks and not the benefits of taking medication. And sadly, her mental health deteriorated and she died. And we referred to this constellation of biases because of the complexity of the intersecting risks, perceptions and needs that the women have who we see amongst the women who die, all of which will impact on them in terms of thinking about the messaging that they are also hearing in the media and elsewhere. And just the other point to highlight from these repeated themes, not only do we see medication being stopped and the benefits not considered, but we've still got extremely precautionary labelling of medicines. And as Claire pointed out, this can have significant impacts. These biases perpetuate throughout clinical care. And here's an example actually from a woman who had COVID in the 2nd wave of the pandemic, where although we had good evidence that dexamethasone was effective, it was considered but not given. She additionally was an ethnic minority woman, so our assessors felt that her care was compromised because she was an ethnic minority woman. And similarly, even as we went further forward into subsequent waves, we see examples like this, where a woman who was really severely ill because she'd had gestational diabetes in a previous pregnancy, they were conducting a literature review on intensive care to see whether she could have steroids when she was clearly extremely compromised. So I guess the perception, we have to think about women's perceptions of risk, and as well as those messages are also going to clinicians working outside of maternity. I know that many of you will have heard me talk about this, but the challenge that we faced because women were excluded from those vaccine trials, we had no evidence of safety in pregnancy as a consequence, and the very high levels of vaccine hesitancy meant that for me, in my role as lead for the confidential inquiry, I was counting one woman's death a week during the winter of 2021-22, at which time pregnant women's mortality rate was about 4 times higher than it had been in previous waves, whereas for all other populations it was about 4 times lower. For me, directly attributable to those risks and risk perceptions. And this was just a very quick examples of lots of the headlines that the media is focusing on, that women are being bombarded with, that the WRISK Project brought out so nicely. And these were the particular parts that really hit home to me, particularly at the bottom. When scientists can't rule out the possibility of harm to the baby, women should be advised to take a better safe than sorry approach. And you'll see I strongly agree, or tend to agree, for the vast majority of women, which is means that benefits just aren't being considered. Very clear evidence of benefit when we look at vaccination, but we're still having challenges with hesitancy. And that brings me back to deprivation, and we have to think about the differential impact of this risk messaging. This is the trend that is going very much in the wrong direction. That top bar is women who live in the 20% most deprived areas in England, and you can see that their maternal mortality rate is increasing and is 2.5 times that of women living in all other areas. And this is just an example from a very nice study that Jenny McLeish did, with hearing the voices of women from multiple disadvantage, and you can see how the risk messaging might have even more impact on them. And I think we all have to be part of the solution. We've got to recognise all of these wider system influences that we need to be considering to improve maternity care, which influence women's perceptions and choices, but actually influence the perceptions and choices of other clinicians and staff who are caring for women. We need to be the people to recognise the woman at risk and be her advocate, and make sure that those messages around benefits and not just risks are being communicated. Thank you.
Thanks very much, Marion. I think those of us who are familiar with Embrace's work, you know, we read those stats regularly, but they never get any less chilling. I think particularly for those of us that sat and have spoken to the women that participated in the risk study, to see how, like, what the possible outcomes are and how grave they are, is frightening. And we should all be frightened and remember that it's frightening, and use that fear to do something about it. We've got plenty of time at the moment, and so I thought I might pause here and address some of the questions that are in the Q&A before we move on to the next part of the webinar on the Dr. Heather Trickey Essay Prize, if that's okay. Sorry, Marion, I'll just unpin you. Do that in a second. Okay, so the first question that I thought I'd get Claire to answer, if possible, is from Charlie Colgate, who we know from her previous time at the Wellcome Trust. And she asks, what are your thoughts on why these particular media stories about research findings are so popular with news outlets?
Hello, Charlie. I think that is a great question, and yeah, I mean, without sort of ending up with a very big answer, I do think there is something about, and we talked a little bit about it, you know, with the BMI issue, that it feels like these big sort of social, and I'm not going to call obesity a moral panic issue, but sometimes it feels like it takes on that sort of proportion. And it feels like these big sort of social concerns that somehow they do end up playing out on women's bodies, and I think the idea of a sort of simple solution. So for instance, and I do think BMI is quite an interesting example because of, you know, the way in which some of the thinking around that has gone with developmental origins of health and disease, whereby there was this kind of, I guess what some people thought was a very neat idea, that if you could just stop women being fat, you would stop them pre-programming not just their fetuses, but their fetuses that the children their fetuses go on to have, if that's not weird. It all seemed very neat and simple, and I think the intentions of DOHAD researchers from the outset was actually, you know, to well, to really improve public health. And I don't think they ended it. I don't think their intention was to end up with these very individualized messages or for it to play out in the way it did. But certainly I do think with obesity that's where it's landed. And I think so I'm now not really answering your question, but I think another interesting example actually is around smoking, where you think, well, how have we reduced smoking in the maternal population? And probably that has gone hand in hand with a society-wide approach to the reduction in smoking. It can't just be about women as mothers, I think. But yeah, I do think there is something culturally intrinsically resonant about women and their pregnancies, and I think that then gets portrayed in media headlines. But I think just very quickly on the study itself, as Julia said, I think sometimes there's this sort of notion of, it's the Daily Mail that just distorts everything, but that literally was not what was happening. These reports were actually very faithful, and sometimes the journalist was adding caveats that didn't exist in the original study. And I think, again, this becomes then a very big question, but I think ultimately we've got to start at the beginning. What questions are being asked and what gets funded? Because I have to say, sometimes it felt like the studies were being written with actually a very clear idea of what the headline was going to be. That sometimes it felt studies were being written up that, despite their findings, were being written up in a way to support a particular narrative, because ultimately ultimately we all occupy a cultural environment. So I do think there is something about how do we have these discussions that start to change the narrative and start to change not the questions being asked and how those results are then framed.
Thanks, Claire. And there's another question here from Sarah, which I think I'll pick up on. It's related. She asks whether women mentioned in the interviews if they were affected or influenced by media reports of risk. This was talked about in depth in the interviews, and as you'd expect, we got a range of answers. Some women, said literally, "Oh, I took it with a pinch of salt," whereas others were really preoccupied by things that they read in newspapers. And I think that just goes to show, actually, we all have different appetites for risk, and we all have sort of different responses to risk messages, and just sort of makes the case even stronger, really, that we really need to think about the individual in front of us, how they want to receive information and what's important to them, because we all react differently to these messages. So hopefully that answers your question. I'll take a couple more and then we'll move on to the next part, but I will make sure we answer all of your questions at the end as well. Catherine asks whether she said, interesting that even well communicated topics reach less than 50% of women. As for the good versus poor communication, do you think this is related to simplicity, i.e. some messages, for example, what to eat and drink, are quicker and easier to communicate than others? And I think, Julia, you'd probably be a good person to pick up on this one.
Yeah, I think absolutely. When you look at the number of topics that midwives are now expected to include in any antenatal check, that it's almost inevitable that if there's a clear message, it's much easier to tick the box and give that message. Whereas if the message is try not to get stressed in pregnancy and reduce your anxiety. I mean, what am I supposed to do to a woman who's nearly homeless, who's got a violent partner, who's got no money and is wondering how she's going to feed her other child tonight? Actually just saying, try not to worry during pregnancy. It's just absolutely patronizing, never mind unhelpful. So if we're going to give these messages, as the participant said, they have to come with practical solutions. We have to be able to take the time to understand the real issues for women. and to actually know the answers before we start embarking on the questions, I think.
Thanks, Julia. And while I've got you, I think this is quite pertinent to you as well. Jenny Hall asks, how much do you think some of these issues would be mitigated by relational and personalised continuity of care?
I don't want to go near continuity of carer, but of course it's got to be improved. Assuming you actually like and get on with the person that you're having continuity of care from. But it's so much easier to look after people that you know. And I don't think there's a health professional in the land that doesn't like to get to know the people they're looking after and build those relationships. It's got to be improved. It just certainly must be, you know, to be able to take the time to understand the complexity of women's lives and how we can best support them has got to be beneficial. And it's a shame, isn't it? Because it used to be that continuity was completely standard. You remember the days when the family doctors were family doctors, whereas many women now, when you talk to them and you say, who's your GP, they don't know who their GP is. They're registered with the practice, and they see whoever they can. And the same goes often for obstetric clinics and midwifery clinics, unfortunately. So absolutely, continuity and relationship building has got to be positive, and it's got to be good for women and for health professionals. And I'm sure lots of the examples that Marion shared just shows that lack of continuity and women going from pillar to post without anybody actually seeing the whole story.
Yeah, thanks, Julia. And then I think we'll finish with a question to Marion before we move on to the next part. But as I said, we will come back to these afterwards. Marion, this question's from Professor Ellie Lee. Do you think JCVI and those making decisions on including pregnant women in the COVID-19 vaccination programme contributed to the problem of over-precautionary thinking? Could they have been reassured much earlier, despite them not being included in trials, especially in the light of international experience?
So I think JCVI were between a rock and a hard place. The fundamental problem was the lack of information, and I attribute that to exclusion from trials, but also exclusion from data collection even early on. So even once women in the higher risk groups were being vaccinated in pregnancy, although everyone was being asked whether they were pregnant, nobody was actually collecting those data. So we were then not able to look at pregnancy outcomes. So I'm obviously an epidemiologist, so data are everything. So I had to present those deaths data to them in December 2021, and that's when the pregnant women policy changed. Yeah, I think it should have changed earlier. It is an interesting reflection as to whether there are advocates with pregnancy expertise at all levels of these kind of decision-making bodies, and I'm not sure there are yet, and I think that's the next step.
Thank you, Marion. Okay, so as I said, we'll get to everyone's questions. I'm really pleased there's so many and they're all such great questions. But now we'll move on to the next part of the webinar, which is focusing on the Dr. Heather Trickey Essay Prize. So just to give you a little bit of background on the prize for those that don't know about it, it seeks to build on the work of Dr. Heather Trickey, who some of you may know died in July 2021. It seems like a lifetime ago already. And she was massively involved in the WRISK Project. It wouldn't have existed without her, but she was also really involved in designing the ward herself. So the prize encourages work that aims to find common ground and practical responses in sometimes difficult areas of women's reproductive health and rights, which absolutely encapsulates Heather's approach to her work. Part of the WRISK Project was about building a big tent and inviting everybody in, and that was a really important thing for her. And so that ethos is reflected in the prize going forward. So the team were looking for essays that spoke to an underexplored or contested area, which sought to surface women's voices and experiences, but also suggested fresh solutions. And so there were 2 winners this year, and they were Sarah Fishburn and Jen Campbell from the Pelvic Partnership, with their essay, Pregnancy-Related Pelvic Girdle Pain is one of the most common, painful and debilitating conditions that you've never heard of. And Angeline O'Connor with PGP, Me, and the 1 in 5 women affected. And we're delighted that Sarah and Angeline are both here to share their experiences today. So Sarah has chaired the Pelvic Partnership since it became a registered charity in 2002. She has personal experience of pelvic girdle pain during 3 pregnancies and the challenges of accessing care and support. She answers the Pelvic Partnership's helpline and leads the committee of amazing trustees and volunteers. She's worked as a lay reviewer of maternity services for several organisations with a particular interest in improving the quality of people's experiences of using health and care services. And Angeline is a mother of 2 with lived experience of pelvic girdle pain. She's a proud trustee at the Pelvic Partnership and has been volunteering for almost 2 years. Angeline is an active member of the Health and Social Care Alliance Scotland and a member of the Alliance Women's Health Plan stakeholder group. Angeline is also the founder of PGP and Me, an Instagram page created to share her PGP journey in an attempt to help others realise they're not alone and that PGP is treatable. So without further ado, I'd like to hand over to both Angeline and Sarah for their presentation. And then once they're finished, we'll open the floor back out for questions.
Okay, thank you very much. And it's a real honour to be here today and to talk to you about pelvic girdle pain and to have won the Heather Trickey Prize. And I can just identify so much with a lot of the things that have already been said in what we hear from women and the work that the Pelvic Partnership does around supporting women and listening to women and trying to help them find a way through. So I'd like to thank the judges first for their understanding of PGP and for choosing us and for supporting our mission at the Pelvic Partnership to improve recognition, treatment and support for women with PGP. Our coordinator Jen, who was part of a joint author of one of the essays, is unfortunately not able to be here as part of the presentation, but I just want to record how grateful we are to her for all the work that she does for women and to support the Pelvic Partnership. So I'm going to share some slides which are here. And hopefully, there we go. So I'm going to start by introducing pelvic girdle pain and talking more generally about how it affects women, and Angeline's then going to follow by telling us about her personal experience, and then we'll finish with our proposal for changing how pelvic girdle pain is perceived and treated. So PGP is a pelvic joint problem. It used to be called SPD, symphysis pubis dysfunction, but the name changed well over a decade ago as a much better description of what the PGP actually affects, because it affects the whole pelvis, and it can affect up to half of all women and birthing people during and after pregnancy. It causes mild to severe pain in and around the pelvis, the hips and the lower back. So any of these areas can be affected. And this graphics from our free ebook, PGP is treatable, and shows that each woman can be different, so it's not the same set of symptoms for everybody. Most women experience pain getting in and out of bed, sitting or standing for long periods, getting dressed, turning over in bed, all those normal everyday things that women do. And it can affect every aspect of women's lives, irrespective of ethnic background, parity, weight, fitness. It's really debilitating, and it can continue after the baby's born for months or even years without effective treatment. And the Pelvic Partnership was formed 20 years ago as a support group for women with pelvic girdle pain during and after pregnancy. And it really started to offer support and help to signpost women to the care and treatment that they needed to become pain-free. We offer support and information about PGP to women, their families and carers, and work collaboratively to raise awareness about PGP and its treatment. We've all got personal experience of PGP, and as experts by experience, we support women and their families by listening to them and providing the information through various routes on our volunteer helpline, Facebook support group, Q&As on our Instagram stories, and one-to-one support on social media. We hear from women across the UK who feel isolated and hopeless, wrongly believing that nothing can be done. So they're often told that this is normal aches and pains of pregnancy, and I think this really reflects very strongly what Julia was saying earlier about they're told that it's fine because the baby's not affected, and the impact on them is not taken into account. They're often told it's caused by pregnancy hormones, nothing can be done, it'll stop as soon as the baby's born. And it's particularly frustrating for women when that's not the case, and then the baby's born and they still continue to have symptoms. And that is the case for the majority of women. PGP just doesn't get better without treatment. So it's a pelvic joint problem. It's not caused by hormonal problems, hormonal changes, but biomechanical joint problems. So this is me in my third pregnancy, and the only way I could get around any distance was, if I went shopping or anything like that, was to use a mobility scooter, because it was crutches other than that, and I really could only manage short distances. But it's really treatable because it's biomechanical. It can be treated safely and effectively during and after pregnancy, using hands-on individualized treatment, including manual therapy, so physiotherapy, osteopathy, chiropractic. They will assess and treat the pelvic joint alignment and the soft tissue issues around the pelvic joints. And that can actually resolve the cause of the pain, or at a minimum reduce pain levels during pregnancy, and facilitate a quicker recovery postnatally with continued treatment. And this is another example of medical gaslighting for women. So by reducing PGP to a normal part of pregnancy, it enables healthcare practitioners to fob off, ignore and dismiss the pain that women are experiencing, and not give them the care, support and treatment they need. And as well as affecting their mobility and causing pain, PGP can impact on women's mental health, and the stress caused by the pain and immobility is likely to have an impact on both on an unborn baby and on the other children impacted by their mum's inability to carry out her normal parenting role. We undertook a survey of women with PGP and asked about the impact on their lives. And this is what they told us, and just a massive impact on every element of their lives. We asked women what support they received and needed, and again that they told us that more was needed. COVID has particularly exacerbated problems accessing NHS physiotherapy, manual therapy. Prior to the pandemic, some hospitals offered really good service, providing expert manual therapy, whereas others provided only advice and exercises. But since the pandemic, women have been telling us that they're only being offered advice and exercises, usually over the phone. And as a consequence, only those who can afford to pay for private treatment are able to access treatment. And this is increasingly reflected in contacts to us. And this is something that we feel really strongly should change. So I'm going to hand over to Angeline to talk about her personal experience and that of other women who contact the Pelvic Partnership.
Thank you, Sarah, and thanks again for having us both at this event. It really is a pleasure to be here, so thank you. The previous slide that you saw, the word map, it was sent in, it was created rather off the back of the essay that I wrote for the Heather Trickey essay prize. And these words were given by real women who experience PGP on a daily basis. And, you know, I have 2 kids and had PGP in both pregnancies, and my youngest will be 6 in July, and I'm still recovering. I'm getting there, but it's a growing road, and I can really resonate with a lot of the words that are in this on this slide. And so the next slide goes on to my second pregnancy, and yeah, just really, again, all the feelings that I had were really, you know, similar to what you saw in the previous slide. It's just the guilt as a parent, as Sarah said, about the inability to be the mum that you want to be to that little girl in the picture who was only 8 at the time. And, you know, I guess in that photo, like, it's amazing how as women we can put on a really brave face, but in absolute agony I was standing there. I was 6 months pregnant in Santa Ponsa, and it was just, I wish I never went on holiday because it was just absolutely brutal. And it's just a really, really difficult time at what should be a really joyful time in a woman's life. Next slide, Sarah. And then this is me with my second. So this is the day he was born, and I was booked in for a planned C-birth. And I guess, like, even the birth with PGP, PGP started at 14 weeks with my second, and it was just horrific. It was every second of every minute of every hour of every day. And I remember waiting to be taken down for surgery, and there was 5 ladies in front of me, and I was told that I was the last to go to theatre because all of these women had pre-existing conditions. So a woman was obese, gestational diabetes, multiple births. And while, you know, it's understandable and you can appreciate that these women had these conditions, it really makes you feel worse about your condition, because you've effectively spent the majority of your pregnancy in absolute agony, and that impact that it has on your mental health as well as your physical health. And then you're sitting on this bed for hours on end waiting to go to theatre. And again, like, throughout your whole journey with PGP, you're put at the bottom of the ladder again, because it's effectively just classed as a woman in pain. And the narrative really needs to change on that so that we can support women better, because the way that I felt in both pregnancies and even post-birth was, well, as long as the baby's okay, as long as your children are okay, you just have to suck it up and get on with it. When in actual fact, you're struggling massively physically, mentally, emotionally, and it affects every part of your life. And next slide, please, Sarah. And so this is me with Eli when he was only about 2 weeks old, and my husband took this picture, and I was just sitting there in an absolute daydream, because I realised at that point that the PGP wasn't going away. So PGP didn't last postnatally with my first, but with my second it absolutely did. And at that point I just had realised that this is just not changing, and it was just a really, really distressing time for me. You're dealing with everything that comes with being a new mum, night feeds, tiredness and everything else, and you just can't experience the joy that you want to experience in that newborn stage, because it's just so overwhelming having this chronic pain. Women that I've spoke to have been told to stop breastfeeding because they've been told that it's the breastfeeding that's causing PGP, and it's such inaccurate advice, and it's really heartbreaking, because they then stop breastfeeding and they have this double whammy, that they are let down because they then expect the pain to go and it doesn't go, but then they also have the grief that comes with being deprived of that breastfeeding experience with their baby. And it's just so unfair, and really does have to change. Next slide, please. And so these are just a couple of photos to give you a flavour of life, you know, like longer term for me. The photo at the top was taken by my daughter. I didn't even know. I was lying in her bed, just in absolute agony. This was September 2021. So my little one was 4 by then, so it just shows you how much time has passed and still how much pain I was in. But it's just the impact that it has on you. And down the bottom, there's a photo that I took myself. I was packing an overnight bag to go away with my husband, and these items just become a daily part of my life. And it wasn't until I was actually laying them out to pack them in a bag that I realised that I really heavily depended on them and relied on them. But it's the impact that it has on everything else, you know, missing out on social interactions or going to baby classes because you can't sit on, well, I personally couldn't sit on the floor because of the pain. So you don't make friends with mums and go for coffees the way that you would like to. And then you become isolated, you become depressed, you have very little patience for your kids because you're in constant pain, and that is so difficult to deal with. And then you feel again really guilty as a mum, and it's not just about the kids, you know, it's your relationship with your partner, and painful sex is a huge one for PGP, and it's very common. So it then affects intimacy and your mood, and it's really hard. And you know, fortunately for me, I have been able to afford private manual therapy by seeing physio and chiropractor. But one of my main drives is because I know that there's so many women in society that are not in that position. And so I'm really passionate about raising the profile of PGP and what needs to be done, and the message that it is treatable, because there are so many women out there that deserve better, and it's just not an option for them to be able to afford care. So, you know, that's one of my main passions in doing what I do with Pelvic Partnership. And next slide, please. And so this is a photo of me and my family. This was us the first time we went to the cinema together, and my little boy's probably about 3.5, but this is just an example of the types of things that you miss out on with experiencing PGP and experiencing it in longer term. So cinema just wasn't an option for me, and we love to go to cinema and just relax and switch off, but for years it just became normal that mummy didn't go to the cinema. And there was a couple of reasons for that. Was the pain. So I just couldn't sit at all for that length of time due to the pain around my pelvis and coccyx area. But then also because of the decline in my mental health, because of the chronic pain, I just could not face. It was the anxiety that surrounded going into that environment, and the lack of control, you know, being able to sit there and worrying about being in so much pain, but then having to get up and disturbing other people. And it just grows arms and legs. So it's just so much more than pregnancy pains, which is what we're told we're told that on a regular basis from health professionals. You just don't have desire, as I spoke about earlier, you know, you're irritable, you're anxious. And then it reached a point where ultimately, you know, I was starting to make plans to end the life because I just could not cope any longer. I didn't want to live anymore. And thankfully I knew that it wasn't healthy, and reached out to my GP, and I really found strength in, you know, the darkest of times, because I guess there's only one way to go from that, and it's back up. And it really was, you know, finding the strength to just, okay, how can we really tackle this head on and deal with it going forward? But not everyone will reach that point and will unfortunately take their life due to the chronic pain. And just another thing about child, and my youngest, I had a very anxious pregnancy due to the pain, and my youngest is a really anxious little boy, and a lot of the time I do worry, and I wonder whether it's related to the experience that I had during pregnancy and also postnatally, because my mental health really was not in a great place when he was younger, and I do wonder if that has sort of projected onto him. So it really is more, we're told in clinics about how, as long as baby's okay, but in actual fact, we really need to think about mum, because what is mum then putting on to baby through her own experience? The next slide, please. And this photo was taken just recently, actually, and it really just, I wanted to just emphasise how, as much as PGP has, you know, is affecting me long term and continues to do so to an extent, It's severely under-recognised in that the message that we're told about how the pain will go after pregnancy, it will stop once the baby's born. This photo was taken in January this year, and it really triggered me. I was in town with my husband and we passed here in the car, and it triggered me back to being 17 weeks pregnant and being stuck halfway up the hill on the way to my very first physiotherapy appointment due to PGP, and I just couldn't move. So I was just stuck in a street in Glasgow and really just didn't know what to do with myself, tears streaming down my face, really emotional, and really struggled to get to that appointment. And what's amazing is that, you know, all these years later, I was still triggered by the sight of that sign, because I remember in the distance I could see that sign and kept thinking, how am I going to get there? I don't know how I'm going to get there because of the pain that I was experiencing because of PGP. And so it really has remained, you know, a really prominent factor in my daily life. Next slide, please, Sarah. And I just want to finish off by leaving you with this poem that I'm going to just hold it on the screen just now for you to have a look. But I discovered this recently and it's really powerful. I think as a society, we really need to change the narrative. We're so focused on the baby being okay, looking after the baby, but what about mum? People talk about coming to visit the baby and, you know, we're coming to see the baby, this newborn baby, etc., etc. The baby's okay. The baby has everything and more majority of the time than it needs. But in actual fact, it's mum that really needs held. And this really spoke to me because it really made me think about my PGP journey and the PGP journey of others that have very kindly and honestly shared with me. And it's really powerful because a lot of this is the way that I've felt during PGP, and if we could just take some focus away from 100% of what it feels like being on the baby and just start to look after mum and really think about what does she need, what is she telling us, what does that mean, what can we do for her, then perhaps we could do better going forward. Thank you.
Okay, so I'm just going to pull together what we've both spoken about, and to conclude, really we think all this can change, and we think that the Heather Tricky Prize offers us an opportunity to move things forward, so we're really excited about the opportunity this is presenting us. We described PGP as one of the most common painful and debilitating conditions that you've never heard of. We recognise that broad changes to NHS policy are needed to reflect the prevalence and impact of PGP on women's lives. It can be safely and effectively treated during and after pregnancy, and we think it's essential to raise awareness of this and facilitate access to treatment for all women, not just those who are able to pay for private treatment in this post-COVID world. We think particularly there should be a focus on improved education and awareness about PGP amongst healthcare practitioners, including symptoms and the impact of PGP on women's lives and the short, medium and long-term consequences of women not receiving treatment they need. In addition, we think there's a need for upskilling of NHS physios to ensure that they have the skills and confidence to give all women with PGP a hands-on assessment and individualised treatment, including manual therapy. And finally, we think it's crucial to ensure that all NHS services take PGP and its physical and psychological impact seriously and offer appropriate treatment, including manual therapy, to all women at an early stage and regardless of ability to pay. So importantly, we think that if there's not a broader cultural shift at the heart of the health and care system to place a higher value on the voices and experience of women and birthing people, then these proposed solutions only have a limited chance of success. And just in the words of one of our service users who shared her experience of how getting informed care, support and treatment impacted on her, she said, "My PGP started at 10 weeks pregnant. By 18 weeks, I couldn't walk on my left leg and was in constant pain every time I moved. I've had 4 sessions of manual therapy with an osteopath, and now I can walk on my left leg and the pain is a lot more bearable. Thank you. You change lives with the work you do. And thank you for your support to help us take it forward."
Thank you so much, Angeline and Sarah, and particularly to both of you for sharing such intimate and personal experiences and such intimate and beautiful photos as well. It's much appreciated window into your experiences. If it's okay with everyone, we're going to jump on to some more questions. Before I get to the questions in the Q&A, I just wondered whether any of the other panelists had any questions for Sarah and Angeline, and if you did, please just go ahead and ask them now.
Well, thank you so much for sharing that. I can only echo what Rebecca has said about, yeah, it's such an intimate portrayal of such, yeah, incredibly challenging situations. I wondered if you just thinking about some of the discussion we were having earlier as well, could you reflect at all on the way in which some of the issues around, say, medication use impact upon women's ability to access pain relief during pregnancy? I know, you know, we're also saying there's a you know, in terms of women's access to physiotherapy, that's got to be a big part of it, but I wondered whether that was also a component of it as well.
Absolutely, there's a huge range of what women are offered. So sometimes they're told, oh, take paracetamol. I remember I was told to take paracetamol, and you can only buy it in a box of 8 or 16, so that only lasted me 2 days, and I couldn't walk, so actually trying to go back every 2 days to get more paracetamol was a nightmare. But some women are told not even to take paracetamol, and then at the other end of the spectrum there are women who are given tramadol and codeine and all sorts of, you know, really much more effective, but obviously medication with side effects as well. So there isn't consistency, I think, as you identified earlier, and we get a lot of conversations on the helpline about, well, I don't want to take any medication because I know it's really dangerous. So where there are some women who are happy to take it, some won't even take paracetamol.
Thanks, Sarah. Okay, we've got loads of questions to get through in just the 15 minutes that we've got left, which is lovely, but it's going to be a bit of a challenge, so I'm going to get started with them straight away. I think this is a question for Marion, and it's from Rachel Arkle. She says, for my PhD research, I'm looking at the prescription of sodium valproate among women and girls of childbearing potential. In speaking with consultant neurologists, many have told me there's a huge divide among the profession as to whether valproate should even be offered as a treatment option in initial conversations. How are we able to ensure that women of childbearing age are able to access effective medication if this is their priority, if 1, effective options are not always offered, and 2, shared decision making is effectively prohibited?
Well, what an easy question to answer. So I strongly feel that the way we're going with valproate is not the right way. I absolutely agree that women have to be, it has to be shared decision making. Women have to know all of the information, but there's absolutely no doubt in my mind that there will be some women for whom valproate is the only drug that effectively prevents their seizures, and we therefore have to recognize that you are, you know, you're weighing the risk of a woman potentially dying from uncontrolled seizures versus the known side effects of valproate. I guess the other challenge that I'm seeing is that women are not being offered prescribed valproate, but neither is there effort being made to optimize their epilepsy with other drugs. And that's the challenge that I don't quite understand why we're not tackling that challenge. There seems to be an assumption is, oh, she's not taking valproate, everything's okay, rather than actually making sure that the treatment she is receiving is effective. I don't have an answer, but we need to do it.
Thank you, Marion. It sounds like you and Rachel should probably connect. I'm sure you both have lots to talk about. I think this is probably another good question for you, Marion, if that's okay, from Charlotte Bevan. She asks, for those risks that you can't mitigate for as a mum, for example, your ethnicity or level of deprivation, or I guess as we found in the WRISK project, your weight, how should these be presented to women? The presentation of heightened risk works powerfully in terms of advocacy and awareness, but will inevitably cause women anxiety for a risk that she cannot alter.
Yeah, I saw that one, and unfortunately I know Charlotte's had to go, and I think it is really important, and I think the language is really important, and I don't know whether people won't have noticed. This is my personal the language I try and use in the confidential inquiries is forward looking rather than backwards looking. So what we need to be thinking about are actually presenting to those women what they can do, what they need, you know, what are their care needs to ensure that any risks are minimized. And it's interesting, it picks up to me the reflection we had earlier about interacting with journalists. And I think as researchers, we do have to think about what we're doing. You know, are we headline seeking, or are we actually trying to get the messages out to women that we want? And I very much would try and use the media to actually get those preventive messages, those positive messages out to women, rather than the headlines, or the NHS is dreadful, or women are at higher risk. The absolute risks are crucial, and I think we've all said about presenting absolute risks, and it's why I try always to emphasize that, you know, maternal mortality, we're talking about 1 in 10,000 women, but yeah, it's so for me it's trying to it's finding the positives to enable women to be reducing their risks rather than just presenting them with risks.
Thanks, Mariam. This is a question from Catherine O'Brien, who's with us at BPAS, and it's for Sarah and Angeline. It's just disappeared because I think Sarah has answered it for us. But it was a question about, because obviously there isn't very good NHS provision for care, as you two described, are private practitioners adequately trained to look after women who are experiencing PGP?
Yeah, so I mean, it's basically the same as if you were a rugby player. Often a sports injury physio is a really good person to go and see if you've got PGP, because they're very good at sort of mobilizing the pelvis and realigning it. It doesn't need to be women's health, and in fact often women's health physios are much better at kind of continence and tears and that kind of thing. So somebody with manual therapy skills, but all physios will have that as part of their basic training, but it's just whether they go on and develop it further. The thing that often blocks the getting treatment is the fear of treating a pregnant woman, because it during the training it's often kind of presented as a contraindication that, you know, she might fall apart or break because she's pregnant, very similar to the medication type issues. So I think I used to run a course for physios and osteopaths, sort of separate to the Pelvic Partnership, and that was one of the key messages that we were getting across, was actually just, you know, you might need to maneuver slightly differently to treat around the bump, but you're just treating this woman like you would, you know, a male squash player who's hurt his pelvis. It doesn't matter who you are. Yeah.
Thanks, Sarah. I think that's a really important message, isn't it? Just to treat the woman in front of you. I know that's something that Marian's written about very passionately, and that's sort of the impetus behind the whole WRISK project. And sort of obviously not forgetting the pregnancy. The pregnancy is an incredibly important part of her and her plans and her family, but treating the woman in front of you is just so important. Thank you. This is a question from Nicola, and I think I'm going to ask Julia this one because we've spoken about this before, I think doing our own research with the many papers we've written together. Does anyone know, Julia, is the presentation of maternity/pregnancy risk similar in other countries? Having lived abroad, it seems to me on returning to Britain that Britain in general has a very over precautionary thinking culture in general. You trying to? Oh, yeah.
Sorry,
you're unmuted now. Yep.
Yeah, I think the honest answer is I probably don't know as much about this as I should do, and I'd like to. I would imagine that it varies enormously. and it probably reflects culture. Oh, Claire's wanting to leap in, I think. So were you leaping in or just?
No, I was thinking whether Marion had something on this as well, because certainly on the COVID, on the vaccine initially, I think we were one of the most precautionary, weren't we? Like it felt like there was a more nuanced approach, at least even in the States, where I think, you know, I started off with the kind of, how can we join up the dots with some of these issues around the protection of the fetus, which I think we think of as a more heightened issue in the States, in terms of, you know, women getting imprisoned for, you know, drug use that harms their fetus. But actually, you know, I think even there was a more nuanced approach to how vaccination was rolled out. It felt like here we had a particular bent.
Yeah, I have to say, having, and this is not scientific at all, but just my experience of Canada, their message around alcohol in pregnancy is absolutely brutal. It's you know, on the back of every toilet door is more or less a sign saying, if you drink in pregnancy, your child will be brain damaged. It's absolutely brutal. Whereas I think probably collectively we're all very poor at talking about the impact of male alcohol consumption on violence against women who are pregnant. And so there is this sort of complete misfit between easy pickings and actually things that are far more complicated. Where, you know, where are the messages on the backs of male toilet doors saying, please don't go home and thump
on alcohol bottles? Why is it just, sorry, but why is it just a pregnant woman on an alcohol bottle? What, you know, yeah.
So yeah, well, so I don't know if you want to come, if you want me to come in. So the US, as far as the American College of Obs and Gynae came out very early and recommended vaccination in pregnancy, and they also started collecting information very early. The CDC did, and because it's a big country, they had lots of information relatively quickly, so they had information to guide practice. Interestingly, I work very closely with a colleague from Norway, and their vaccination committee, equivalent of our JCVI, held off recommending vaccination in pregnancy until I think about May. So we had that very first recommendation right at the end of December 2020, just for very high risk women. And the Norwegian team held off until May. But at that point in May, they'd got lots of information from the US, even got some information from the UK. So there was lots of information, which they could put lots of reassuring stats in their recommendations. So, and they've got very, very much higher vaccination rates in pregnancy because they were able to give women all the information they needed at the point they made those recommendations, which obviously we were not able to. I don't know why ACOG has a stronger voice than RCM, RCOG, who were also advocating in this country. I don't know the answer to that. Interesting question.
Thank you, Marion. So there's another question here from Catherine Kelly. She asks, do you feel that the Montgomery versus Lanarkshire finding, i.e. what is material to the woman, should be used to inform what information is shared with her? I guess the WRISK project looked at risk messages, public health information that existed across like the whole risk ecosystem. So what information was given in a clinical environment, in addition to what information women receive from their families and friends, the mainstream media, as we've discussed, books, the whole thing. But I wondered whether, Julia, you could talk about this in the context of like a clinical consultation.
Yeah, certainly is. So for those of you who are not familiar with Montgomery, this is the tale of Nadine Montgomery, who I can't remember how many years, a good few years ago now, was pregnant with diabetes and was not offered the option of a planned cesarean section, and her boy, her son who's now her son, experienced a sort of got stuck with his shoulders during the birth. So the claim was around, it took many years for it to be established, and several court hearings before it was established that in conversations and when having conversations with women, clinicians, and that's midwives and obstetricians and anyone else who comes into contact with them, must give information that would be relevant to that individual, and not just basically fob them off. We absolutely need to establish in any relationship and in any conversation what is important to women, and gear our conversations in that way. As I think you've already said, Rebecca, some women are natural worriers. They will worry about everything, and they will happily tell you that they worry about everything and they want to avoid everything. And okay, let's talk about that. And some women will go, do you know, I really don't want to know. I'm just going to go with the flow. And so yeah, it is about developing relationships, seeing, as you said, seeing the woman as a whole in the context of her whole life, and not just giving partial information, and the information and only the choices that we want women to make. And that was absolutely fundamental to Nadine Montgomery's case, was the obstetrician didn't want to mention cesarean section, because if she did, she thought women would choose that option. So it was a choice that was not given, and we have to learn from that. Women need to make informed decisions that are right for themselves and their baby and their family in the context of their lives.
Thank you, Julia. We're very quickly running out of time. There's still quite a few questions in the Q&A, but what I'm going to do with the remaining ones is make sure we get written answers to the attendees. But there's one question that I'd like Claire to answer before we wrap up today, and it's from Ellie. She says, thanks so much for the comments and presentation. What are the impacts of what you did that you are most pleased about so far? And how do you think this work, i.e. the WRISK project, could best be developed further?
Thank you for that question. And yeah, I think we're all really proud of this work, and I think that the conversations that have initiated off the back of it. And I do feel like progress, which isn't necessarily down to the WRISK project, but you know, I do think there are different conversations happening around medications, and I was, you know, really pleased that that WRISK was invited to come and give a presentation to the MHRA's. Is now part of the MHRA Safer Medications in Pregnancy group, which I actually think started on with more of a how can we stop women taking medications, and actually is ended up with more of a actually how can we get really good information out there to women that also puts women's experiences and needs you know, well into the picture, and that is a phenomenal group of people who, as I say, it's not, you know, I think a lot of this discussion is going on. There are some brilliant, you know, groups and individuals out there taking this forward. I do think personally, I think sodium valproate is a really important line in the sand, though, because I think it raises a whole load of issues that I think are really problematic and I think set a very worrying precedent. How do we take this work forward? I think through these kind of collaborations, I think one of the great strengths of the WRISK project actually was, and this was, you know, a tribute to Heather, who was always about consensus building, whereas I was much more the person sort of shouting in the corner. Whereas, you know, actually for me as an individual, that has been a great learning process, that actually, you know, we make progress when we work together, and we don't have to agree on everything, all the time to work as a collective. And actually, generally, we're all out there to achieve the same things for, we all want the best for women and their babies and their families. And yeah, I think the more we can collaborate on pushing forward on that, better for women and their babies and their families.
Thank you, Claire.
Thank you.
Yeah, for me, it's been a real labour of love and a brilliant project to work on. It's been amazing to work with Claire and Julia and Heather and our oversight committee. And so before we finish, I just want to say a few thank yous to them. They were absolutely instrumental in keeping us on time, relatively, not pandemic notwithstanding, on budget. And delivering a project that really exceeded the expectations of what it really set out to do in many ways. It was a public engagement project, and we thought we might get a few publications out of it as a bonus. And to date, we've published 4 publications, which I hope will really shape practice and inspire people to think more about this issue of, I guess, changing the sea in which women swim, which is a phrase coined by Claire at the beginning of the project. So thank you very much to all of our speakers. It's been an absolute pleasure to have you all here with us. As I said, the publications that have been published already from the project are available on the Eventbrite page, along with a short film that we had made to share the voices of the participants of the project. And if you've got any questions, please contact us on research@bpas.org. Congratulations again to Angeline and Sarah and Jen from the Pelvic Partnership. And we'll be in touch with you all, I guess, next year about the Dr. Heather Trickey Essay Prize again. So thank you very much for joining us, and enjoy the rest of your evening. Bye, everyone.